Hello, guys. We're going to do chapter 19, the urinary system and fluid and electrolyte balance. This part will talk about primarily water. So, the overview of the chapter is that we're going to talk about how water, sodium, potassium, calcium are reabsorbed with the urinary system, with the kidney, and end up on acid base. So, the first part of this chapter is basically just an introduction to an understanding of how materials and water move through our body, and there's an exchange between our intestines or the gastrointestinal tract moving towards our blood plasma. So our plasma and our interstitial fluids of our tissues are going to be absorbing different materials from what we take in from the outside. They're also going to be exchanging materials with our cells and also with what is in our interstitial fluid, in our connective tissue. So there's always going to be a back and forth exchange of materials between our blood and what's in our cells and connective tissues. And then that ultimately, our plasma is ultimately going to move to the kidneys to get filtered. So through filtration and secretion, we're going to move those materials into the lumen of our renal tubules. And then, of course, the kidneys can reabsorb materials back into the blood. And so how we lose materials and how we lose water is through feces, through sweating, if we're bleeding or hemorrhaging in our respiration, and then also through urine. So it's a big component of how we get rid of substances, and our kidneys are a big component of how we balance our plasma fluids. So if you look at we're always trying to have balance, right? So homeostasis is having the plasma as well as all those solutes we were talking about, calcium, sodium, in balance. And when we take more in, right, if we have balance, then the input equals the output. If we have what's called a positive balance, that means that we're increasing the content, whether it's water or solutes. And if we have a negative balance, we're decreasing the content, whether that is water or solutes. So the kidneys are going to want to try and always achieve homeostatic balance. So they're going to either secrete or absorb the materials back into our body. So looking at this flow chart is just an idea of how we're moving water. So water is going to be produced or input into our bodies two ways. So it's either through food and drink, which is ingestion, 2.2 liters a day approximately, and then through cellular respiration, because the waste products of cellular respiration are both carbon dioxide and water. So we do get a little bit of water created in our cells, not a whole lot, but it's actually pretty substantial, 0.3 liters. And so our inputs, approximately 2.5 liters a day. Our outputs are going to be through feces. Insensible water loss is sweating, but it's the indetectable sweating that you're always losing. So we're always losing water through our skin. Little bits, right? But it's not perceptible. It's just, that's why it's called insensible. You can't sense it. But then when you start to warm up and you start to exercise, then that's detectable sweat. That's a cooling kind of sweat. So there's two kinds of water loss there. And then, of course, we have our urine. So out of our water loss, what's the biggest component of our water loss is through your urine, right? 1.5 liters a day can be lost. So the kidneys actually have a large role in mediating water loss because you can't really control, there's no hormonal control of water retention through the colon, through the feces, and you can't really control sweating to a large extent, but the excretion from the kidneys is very tightly regulated. So we'll look at that. So talking mainly about water now, water is going to move via osmosis, and osmosis is always going to depend on solutes because water is always going to move to the hypertonic side of a plasma membrane or hyperosmotic. In this case, it's pretty much interchangeable because we're talking about solute ions, and they're not, most of these are not going to be permeable. So we're going to take our solutes and we're going to actively reabsorb those solutes. So from the tubular fluid, this is the filtrate that's moving through the tubules of your kidneys, right? We're pulling out the solutes. Now, the solute that is mainly responsible for a lot of our osmotic pressure is going to be sodium. So sodium is our main solute, but then other solutes, of course, play a role in creating that osmotic gradient. So we can see that we're actively pumping in our solutes, and then they're going to pass through the cells. They're going to take up, so they're going to go all the way through the lining of the tubules, so the tubule cells. Then they're going to be secreted into the peritubular fluid. They're going to enter into the peritubular fluid. And that's the fluid, that's the interstitial fluid. So that's the fluid that's just surrounding the nephron. It's surrounding our blood capillaries. It's just the kidney fluid. And then that is going to then move those solutes into the epithelium or through the epithelium of our capillaries. And so it's going to move into the plasma as well. Okay, so where the solutes move first, then the water follows. So water is reabsorbed by osmosis. And one quick word, that urea is also going to be a solute that is contributing to the osmotic gradient. But in this case, it's a permeating solute. Don't worry too much about that. It's just going to contribute to the osmotic gradient along with our ions. All right, so we're going to talk about this mechanism called the countercurrent exchanger in your kidneys. And I want to this is the broad idea, is that your tubular fluid, which I also call filtrate, right? Because this is what was filtered from the Bowman's capsule. So this tubular fluid is going to move through the PCT, it's going to move through the loop of Henle, the DCT, and then down the collecting duct. And as it does so, it's going to be modified in several ways. And the countercurrent multiplier is going to set up a gradient of osmolarity. So notice that we have over here in the medulla of the kidney, okay, the cortex is 300 milliosmoles. This is homeostatic. This is what our normal osmolarity of our tissues, our interstitial fluid, our cells, this is normal, right? Remember, 300 milliosmoles. Then as we move down deeper and deeper into the medulla, we notice that the numbers go up. So the osmolarity is going to increase very greatly. So at the bottom of the medulla, if you can picture the medullary, the renal pyramid, so near the papilla, right, that's going to be very, very hyperosmotic, very salty. And we're going to talk about how that's set up. Because it gets saltier and saltier, that's going to have a higher and higher osmotic gradient. So it's going to pull water out of your tubules, right? And it's going to get extracted from that tubular fluid, and it's going to go back into our blood supply. So let's look at how that works. So here is a blank nephron. And so we're just going to talk about the different aspects of creating this countercurrent multiplier. So first of all, we have to set up our salty gradient. So I'm going to just change colors here. And remember that we have a 300 milliosmol concentration in the cortex and also at the upper medulla. And then as we move down, we're going to get to a very, very hyperosmotic 1400 milliosmoles. Okay, and how is this done? It is done because the ascending loop of Henle, okay, the ascending limb of the loop of Henle is going to be actively pumping out our ions. So it's going to actively pump out 3 different kinds of ions: potassium, chloride, and sodium. So they're pumped out. And this is going to create that salty gradient along with another solute, which is urea. So you can see urea is actually coming out from the collecting duct here. And we'll get to that in a second. But this is going to create that concentration gradient. Okay, so it's actually pumped out. Now, in order for water to move from the tubules out from that tubular fluid, we need to have aquaporins. Water is a polar molecule. It doesn't move through the membrane naturally, so it's going to have to use aquaporins. So there are aquaporins only in the descending limb of the nephron. And so water, because the descending limb has aquaporins, and this is aquaporin type 1, which is always present and always open, water is subjected to this increasing osmotic gradient that's set up by our solutes, and so water is going to move out down its osmotic gradient, right, out of our fluid. Now, what does that do to the osmolarity of the fluid? It's going to make it hyperosmotic, right? So as our fluid, our filtrate or the tubular fluid moves down and water is getting extracted, that fluid is also, when it reaches the end of the loop, it's also very, very hyperosmotic. It's 1400 milliosmoles. So it becomes isoosmotic with the environment. Now, that's concentrating our filtrate, right? But as it moves up the ascending limb, guess what? It's all those solutes are getting pumped out. So it's getting more dilute. We're pumping out all those solutes. And by the time we get up to the DCT, the osmolarity of that filtrate is no longer 1400 milliosmoles. In fact, it's 100 milliosmoles. And this is going to be important for in just a second. So it's very, very hypotonic, right? Hypoosmotic. Now, let's put the vasa recta in, okay? So we're going to put in a blood vessel, a capillary network. In these nephrons that we're talking about here that can highly concentrate your urine, these are going to be the juxtamedullary nephrons. They're the really long ones that go deep down, and they go all the way down to the inner medulla. Surrounding the juxtamedullary nephrons is a blood vessel, a network of capillaries that is extremely long as well, and it is called the vasa recta. So I'll just draw the vasa recta here, a schematic of it. Oops. Okay. So there's our vasa recta. Okay. So now the fluid or the plasma that's in the bloodstream is going to go in the opposite direction around our loop of Henle. So it's going to go down. So the blood supply is going to come down. Now, as the blood supply is coming down, the solutes that are being moved, actively pumped out of the ascending limb, they're going to move into the bloodstream. Okay, so they're going to take up residence in the medulla to create the gradient, but they're also going to move into the bloodstream because there's going to be a high concentration of these ions in the medulla, in the interstitial fluids, and there's going to be a lower concentration in the blood plasma, and there's going to be channel proteins for them. Okay, so we want these ions to go into the bloodstream. So we can just leave the drawing how it is because we can see that the potassium chloride and sodium are coming into the blood. But what does that do to the osmolarity of the blood? It's going to also make it hyperosmotic, right? So as the blood is moving down the vasa recta, when it reaches that loop, it's also super, super hyperosmotic. It's about 1200 milliosmoles. Okay, so it's super salty blood. Now, as it comes back up, it's going to be permeable to water. Okay, so the capillaries are going to accept that water. So notice that the water is exiting our descending limb, and the water is going to go into our blood supply, right? And this is good. We want this to happen because that's how we're getting the water back from our filtrate, right? Where the water is moving out of the descending limb because it's subjected to a very high osmotic gradient as it moves through the medulla, and it moves into the capillary network because the blood is also hyperosmotic. So there is a driving force. There's a osmotic gradient that moves the water not only into the medulla, because we know that has a osmotic gradient, but also the blood, right? What's the impetus? What's the force that's going to move the water from the interstitial fluid then into the bloodstream? It's because the blood plasma is also hyperosmotic. Okay, so that's important that it's hyperosmotic. Now, it's accepting all this water, and then at the end, it kind of equals out. So it's around 325 milliosmoles at the top. Okay? So far we've talked about this water exchange, right? So just to recap, actually, let's add in a couple of other things. In the notes, I kind of went right in on the countercurrent multiplier, but in the notes, there are a couple places where we reabsorb water at the nephron. The first place that's mentioned is the PCT, okay, the proximal convoluted tubule. This is going to take up water. In fact, if you look a little bit further down in your notes, 70% of the water is reabsorbed here. I'll use blue for water here. So 70% of our water is reabsorbed at the PCT. This is in an unregulated manner. Unregulated means that there's no hormone necessary for the water to move back into the bloodstream. Remember that this capillary network is also all over the place, all over the nephron. So the water that leaves the PCT is unregulated, and it's going to follow the solutes. So the PCT is going to actively pump those solutes out of the filtrate, and the water will follow. Okay, so that's one. The other two places where water is reabsorbed is the DCT and the collecting duct. Okay, so here is the DCT, and then the collecting duct is labeled for you down here. Okay, so the last section in your notes where it talks about water, about 20% of the water is reabsorbed in the DCT. And this is going to be regulated. And then about 10% is going to be absorbed in the collecting duct. And also regulated. What regulated means is that there has to be aquaporin, there has to be a hormone signal. And the hormone is going to be antidiuretic hormone. Okay? So in the presence of antidiuretic hormone, okay, so ADH, see there's ADH here. I'm sorry guys, go back. In the presence of ADH is going to act on the cells of the DCT, and it's also going to act on the collecting duct, and it's going to prompt, just like how insulin was, the insulin receptor was kind of carted up through a vesicle, put up on the membrane, so does ADH. So ADH is going to signal a G protein coupled pathway. It's going to take a vesicle that already has these aquaporins on it, and it's going to insert more aquaporins on the surface of the DCT. So water can only move when there's aquaporins present, and ADH will put those aquaporins into the DCT. So now this is a different kind of aquaporin. It's aquaporin type 2, right? So type 1 was the one that was in the PCT and it was there all the time. But this is going to be aquaporin type 2 that is responsive to ADH, and so it's going to move water. So now, what is going to cause water to move out of the DCT? All right, osmotic gradient. And we have an osmotic gradient. We have one because, remember I said that the filtrate, as it moves up the ascending limb, all of those solutes are actively getting pumped out, right, of the filtrate, and we have a very hypoosmotic filtrate at the DCT. Remember what the osmolarity of your interstitial fluids was? 300 milliosmoles. Now we have a gradient, right? We have a gradient. So the water is going to move down its osmotic gradient and move into the interstitial fluid. And then also into the bloodstream. Why is it going to move in the bloodstream? It has to be hyperosmotic. So remember, this is 325. It's going to remain 325-ish, right? 325 is higher than 100, so it's going to also come in, or it's higher than 300, so it's going to go into the bloodstream. So we have that mechanism at work, this osmotic gradient at the DCT. And then the collecting duct is also going to respond in the same way to ADH. It's going to put up more aquaporins, aquaporin type 2, in response to ADH. And the collecting duct, is going to be subjected to the same osmotic gradient that the loop of Henle was subjected to, right? Because it's going to move all the way down the medulla to the renal papilla, okay? So we have a gradient set up for the collecting duct. We have a gradient set up for the DCT. all that needs to happen is that the ADH needs to be present so that we can put up the aquaporins. And that's going to be based on need, right? The hormone that's secreted, your ADH hormone, antidiuretic hormone, is going to be based on whether or not you need to retain water, or if you're extra hydrated and you have drunk, a lot of water, you can afford to lose that water. We want to always achieve balance. We don't want to flood our bodies with water, right? We need to excrete that extra water. So then you will not produce as much ADH and will let that water leave. One last thing I think to talk about, we'll get to urea in just a second. One more thing to talk about is, let's do urea first. So urea is also the transporters for urea, which is UTA, UTB, and UTC. Those transporters are also going to be responsive to ADH. And so ADH is going to set up a urea transporter, okay? And it's going to transport urea out, as you can see here, right? So the urea is going to come out into the medulla, and it's going to contribute to the osmotic pressure, and it's going to contribute about 40% of the osmolarity is due to the urea in the medulla. So 60% comes from the potassium, chloride, and sodium. 40% is going to come from the urea. All right. So then let's talk about diabetes insipidus. So diabetes insipidus. So underneath in your outline, the countercurrent multiplier, the last little paragraph under number 1 was diabetes insipidus. So remember that as the filtrate's moving through your kidney, the PCT, the DCT, the PCT, the loop of Henle, and then it reaches your DCT, it's 100 milliosmoles. It's very, very hypoosmotic, very dilute. If you did not have the presence of ADH, if you did not make ADH or secrete ADH, that really dilute 100 milliosmolar fluid will leave your body as is. And that's going to severely dehydrate you. If you did not create ADH, you would lose 18 liters of water a day. That is way too much, right? It's not going to work for life. So you need small amounts of ADH in your body at all times in order to reabsorb the water, because if not, you're going to lose way too much water. But if you need to reabsorb more water, if you're dehydrated, then you're going to create more ADH hormone. That ADH hormone will put up more aquaporin type 2s. And also more urea channels, the UTA transporters. Why would ADH also increase the urea transporters? Because it wants to create a higher concentration gradient. The more urea you pump out, right? The more urea you pump out, the saltier this environment's going to get. And the drive of water is going to be even more forceful. So you have a steeper osmotic gradient. More water will leave quicker from the tubules, and you'll retain that water. Okay, so that's why ADH is also involved in both water transporters and also urea transporters. Okay, so I talked about the content in the countercurrent multiplier. Number 2 in your outline, I talked about the role of urea. Urea, by the way, is a waste product from protein breakdown. So the nitrogen that's broken down in proteins will go to the liver makes urea, and the urea is a waste product. I talked about the role of the vasa recta. Now I'm going to just recap the role of the vasa recta. So what's the vasa recta for? 2 things. So the first thing that the vasa recta does is, of course, accept that water. Water back to body. Blood, right? So it's very important because it has to be close to where water is getting taken out of the filtrate and it can go back into the bloodstream. So that's number 1. But number 2, another important role of the vasa recta is because it does take up that water and it takes it away from the medulla can remain salty. Because imagine if the water just came from the filtrate and entered into this interstitial fluid, just right here where my X is. That's going to dilute the solutes that's being pumped out, right? If we're going to make the kidneys watery, then it's going to drive down that osmotic gradient. You're going to have that, you're going to wash out or dilute the potassium, the chloride, and the sodium that you just pumped out. So it's really important to take the water back so it maintains the osmotic gradient of the medulla, right? So it prevent the dilution of that medulla. So yes, we need it back for the body. We need that water back for the body, but also yes, we need the water back because it doesn't stay in the medulla, because if it stayed there, it would completely obliterate that osmotic gradient. So those are the two things that are good for the vasa recta. So we talked about that. And the recap here was just, we talked about number one, how the different percentages, and we have our sort of unregulated water absorption and then our regulated water absorption with our ADH needing to be present. Now let's talk about how we can find, so we can ignore this picture, I just drew it. Now we can find how our ADH works. So antidiuretic hormone is going to signal, it's a G protein coupled pathway, so you're familiar with this. Notice that we have this vesicle with our aquaporin type 2s, and in the presence of ADH, more of these aquaporin type 2s will be put on the apical membrane, the one facing the tubular fluid. Water will move in through osmosis, and water will move out towards the bloodstream, okay, and also through osmosis. This is a look at our urine and how we can concentrate urine. So in this scenario here, letter A, we can see that we have a 100 in the distal tubules, we have 100 milliosmolar fluid. If there were no ADH, it would just be the same 100 milliosmolars as it moved down the collecting duct, and then you would have a lot of urine, you'd have a high volume of urine, it would be very, very dilute, low osmolarity. However, in the presence of ADH, then we can see that we have water being lost in the DCT, and then as the collecting ducts move down through the medulla where it gets more and more hyperosmotic, we're losing water, we're removing water from the urine. So we can really concentrate our urine. The most concentrated the urine can get is about 1400 milliosmoles. But this urine will have very low volume and very high osmolarity. So this is a scenario where you would be dehydrated. Or you start off being dehydrated and your kidneys recognize that you're dehydrated and they're not going to let the water leave through urine. So your body's going to produce antidiuretic hormone, and that antidiuretic hormone is going to prompt that reabsorption of water. And you're going to produce very little urine. Then the last part here is the detection of your body's status, right, with water content. So there's two things here. So remember that ADH is secreted from the posterior pituitary. The posterior pituitary, remember, is actually an extension of those neurons in the hypothalamus. So the neuron cell bodies are in the hypothalamus. Antidiuretic hormone is created there. It moves down. It's going to be secreted from the posterior pituitary. The part of the hypothalamus that's sensitive to osmolarity is going to be called OVLT. You don't need to memorize that full name of it, but you want to know that osmoreceptors are in our hypothalamus. They can detect the osmolarity, right, the solute concentration of the interstitial fluid. This is because it's not surrounded by the blood-brain barrier. Remember that we were talking, if you studied the nervous system, remember back there's a blood-brain barrier. It really isolates the neurons from sort of the normal substances in the blood and in the interstitial fluid, but not this little area. So this is specific for detecting osmolarity. And if the osmolarity is high, we're going to secrete ADH, right? ADH is also, so that's one, it's also affected by baroreceptors. So baroreceptors are pressure receptors, right? Stretch receptors, and they can detect blood volume. And if the volume goes down, that means your fluid levels in the blood goes down, right? You don't have a lot of fluid in there. So you want to that's going to be a signal to retain water because your baroreceptors stretch. You don't have that much stretch anymore. The content of the liquid is low. So the decrease in baroreceptor activity will increase your ADH secretion. These are some flow charts. These should make a lot of sense. There's a different way of looking at it. So if we have more osmolarity, your osmoreceptors will detect it in our hypothalamus. It's going to act to prompt to secrete ADH, and that ADH will ultimately absorb water, decrease the water that's being lost, and conserve water. This is just a picture showing you that we have both osmotic osmoreceptors in the hypothalamus, and I thought we had baroreceptors here, but these are the receptors. This is our posterior pituitary acting on the kidney. ADH, just FYI, has roles that can target other tissues, the skin. It can decrease water loss by perspiration. It can also constrict the blood vessels so that you can increase blood pressure. But we're predominantly looking at the kidneys today. This should also make a lot of sense. A decrease in blood volume will ultimately mean a decrease in blood pressure. The baroreceptors that respond to blood pressure feel that. They're going to decrease their activity. That is going to prompt our hypothalamus to talk to our posterior pituitary and secrete our ADH hormone. ADH then increases water absorption, decreases excretion, and it's going to help return our blood volume to homeostatic measures. And lastly, just a little bit about caffeine and alcohol. So both of these substances that we are coming across every day, or maybe drink every day, or every once in a while, they actually decrease the amount of antidiuretic hormone released by the posterior pituitary. So they limit how much ADH, they inhibit how much ADH comes out. So what do you think this does to urine production? Right? It's going to stop putting your aquaporin type 2s on the DCT and also in the collecting duct. It's going to allow more water to be lost. And so when you drink coffee or alcohol, you have to go to the bathroom more often and you have more dilute urine, right? Because these are going to block ADH. And so these are called diuretics. Diuretics. Because they are going to prompt your body to lose water. Now, diuretics can be good. They actually are prescribed. There's medicines that are diuretics, and that's to decrease the blood pressure. So if you're really high blood pressure, one way that they can treat it is that give you diuretics, and they can get that extra water out of your blood so your blood pressure goes down. Okay, some review questions. Which of the following statements about ADH is false? So pause if you want to think about an answer. The answer is letter C, because it's released by the posterior pituitary. Which of the following is not one of the ways in which plasma and the external environment can exchange materials? So pause it to think. Answer is B, the portal circulation. Didn't mention that at all. The activation of which receptor stimulates hypothalamus, resulting in the secretion of ADH? Oh, the activation of which receptor? And this should be letter C, osmoreceptors. All right, that's it. We'll start part 2